We'll move on to the next speaker, Dr. Atha J. Shit. He's going to speak to us on new medications for glaucoma treatment. Dr. Shit is at the Mayo Clinic, University of Rochester, focuses on finding new diagnostic tools and treatments of glaucoma. His focus areas include non-invasive assessment of aqueous humor dynamics in humans and optimizing treatment of glaucoma, animal models of studying IOP fluctuations and studying impact of IOP fluctuations in persons with glaucoma, and evolving non-invasive techniques of studying ocular biomechanical properties of the eye, including ultrasound vibroelastography. Over to you, Dr. Sid.
Thank you very much. So now that two previous speakers have shown clearly that we don't need eye drops, I'm going to be talking about eye drops. And these are my disclosures. I have been a consultant and performed research for a number of pharmaceutical companies. So when you think about the glaucoma eye drop history, 1997 was a landmark year. That was the year that latanoprost was released into the market in the US. But then after latanoprost was released, there really weren't a lot of developments in terms of fundamentally new mechanisms. And there were other prostaglandins, there were combination drugs were undoubtedly useful, but it took about another 20 years to develop some fundamentally new mechanisms. So what I'd like to talk to you about today are some of the new molecules that have come onto the market, some new molecules that are on the horizon. And in an international audience, it's always hard to define what's new. So for the purposes of this talk, I'm going to be talking about things that have been either recently FDA approved or in phase 2 or 3 clinical trials in the US. When we think about glaucoma medications, it's useful to think about mechanisms of action. So this is the modified Goldman equation, which describes intraocular pressure being controlled by aqueous humor production rate, uvoscleral outflow rate, outflow facility, and episcleral venous pressure. And most of our existing drugs work here. They either decrease aqueous humor production, those are the beta blockers, CAIs, and alpha agonists, or they improve uvoscleral outflow, and those are, of course, our prostaglandin analogs. Drugs in development, though, tend to work here on outflow facility or on episcleral venous pressure. So first, I'd like to talk about nitric oxide. So nitric oxide, of course, is a very potent vasodilator. In the eye, it relaxes trabecular meshwork and Schlemm's canal cells and enhances permeability. It decreases distal outflow resistance when vessels constrict. The problem is it has a very, very short half-life. So the key to making that into a useful eye drop form was to take latanoprost and add a nitric oxide moiety to it, and that was the creation of latanoprostene bunod. And from the Voyager study, very clearly latanoprostene bunod has a little bit over 1 millimeter of mercury greater effect than latanoprost alone. And this was approved in the US in 2017, and it's also approved in a number of countries in Asia. So many of you probably have experience with this as well. More recently, the company that originally developed Vyzulta, Nicox, they're now developing a matoprost-containing compound with a nitric oxide donating group. It's currently in phase 3 clinical trials, but you can see in their phase 2 data, again, it has significantly greater efficacy than latanoprost. Let's move on to Rho kinase inhibitors. So ROCK inhibitors, so Rho kinase-associated proteins modulate cell contractility in Schlemm's canal and in blood vessels. And ROCK inhibitors have a lot of different effects in the eye, and we're going to talk about some of those. In 2018, we went through a clinical trial, a phase 1 clinical trial, to understand exactly what the mechanism of action was of notarsitol in the human eye. And this was in healthy subjects, and we compared notarsitol treatment in one eye for 7 days versus treatment with a vehicle in the contralateral eye as randomized and masked. And then we measured intraocular pressure, outflow facility, episcleral venous pressure, aqueous humor production rate, and uvoscleral outflow was then calculated from the modified Goldman equation. So just a short note about how we actually perform these treatments. So outflow facility is measured with tonography, and in this study we used a digital Schiatz tonographer with a weighted tip, which increases the IOP and which slowly decays back towards baseline over a 4-minute period. And looking at the rate of IOP decay, we can calculate the amount of resistance to aqueous humor outflow in the eye. We also measured aqueous humor production rate, and that's performed with fluorophotometry. So we start by creating a fluorescein depot in the eye with fluorescein eye drops. Over time, as aqueous humor takes away that fluorescein from the eye, we can then measure that rate of fluorescein clearance using a fluorophotometer that you see here. And by looking at the rate of fluorescein clearance, we can then calculate the rate of aqueous humor turnover. Episcleral venous pressure is measured with this objective venomanometer that we developed, and the idea here is that you place a balloon on the eye, you elevate the pressure, collapse an episcleral vein while videoing it and recording the pressure, and then you can go back and calculate the pressure at which the vein just starts to collapse, which corresponds to episcleral venous pressure. And then and the uveoscleral outflow can't be measured directly in humans, so it has to be calculated from the other parameters and using the Goldman equation. So what did we find? So we enrolled 11 subjects, 10 of them completed the study, mostly females and definitely on the younger age. But we found that ILP decreases significantly by about 25% compared to baseline, and also significantly decreased compared to placebo, so no surprises there. We found that outflow facility improved significantly, both against baseline and against placebo. And then we found that episcleral venous pressure also decreased. It decreased significantly compared to baseline, and in this particular group, it didn't quite reach significance when compared to placebo, because for some reason our placebo group also had a decrease in episcleral venous pressure after a week. There was a trend towards a decrease in aqueous humor production rate, but that did not reach statistical significance. And then we found no difference in aqueous or uveoscleral outflow rate. Now, we subsequently went back and looked at patients with primary opening glaucoma and ocular hypertension, and we found really similar results. So significant improvement in trabecular outflow facility, and also a significant decrease in episcleral venous pressure. So why do these results matter? Why are they interesting? Well, first of all, this improvement of outflow facility is pretty unique among most of the glaucoma drops that we use now. Pilocarpine will do that, but a lot of side effects and really not in common use. But when you reduce outflow facility, that reduces your ILP fluctuations, and Richard Brubaker showed that more than 20 years ago. If you were to perform a water drinking test, if you were on a drug that suppressed aqueous humor production, you'd have a very high ILP spike that lasted a long time. But if you were on a drug that improves outflow facility, your ILP spike is much lower and goes back to baseline much quicker. And then how about that EVP reduction? So the EVP reduction was relatively modest. It was about, on average, 0.8 millimeters of mercury. And you may think that's, what does that really matter? And so, but when you think about some of our clinical trial data, especially the early manifest glaucoma trial, they showed that each millimeter of ILP reduction results in about 10% decrease in risk of progression. And so these drugs, this small reduction in EVP may be particularly helpful in glaucoma patients who have especially lower ILP, such as normal tension glaucoma patients. So the mechanism of action of notarsidil then seems to act on both the proximal and distal portions of the conventional outflow pathway. Its primary effect is on outflow facility, but does have the secondary effect on EVP. So it seems to be this rather unique combination of mechanisms among our drugs right now. It does have side effects, and this is from the registration data that ERIA originally submitted for approval, and hyperemia is the most common one. 80% is graded as mild with once-a-day administration. Based on clinical usage, not everyone gets it, but it is certainly common, but typically not something that causes patients to stop their medication. Subconjunctival hemorrhages were reported, especially with initial usage, but really none were noted after 12 months of usage. Corneal verticillata are also common. They are visually insignificant and asymptomatic, and about 30% resolve if you keep on using the medication. One thing that wasn't reported prior to registration is honeycomb edema. So if you have a patient who already has a compromised corneal endothelium, if you start giving them Repressa, they develop this very characteristic epithelial edema. So Repressa was approved in the US in 2017. It's in Asia, it's been approved in South Korea in October of 2024. And of course, Rocklatan combines notarazanol and latanoprost, and that was approved in the US in 2019. So let's move on to omadanemag. I feel a little bit odd putting this one in actually, because this audience probably has more experience with this drug than I do, because it's not approved in the US, but it is an EP2 receptor agonist from Santen. It's a prodrug. It's hydrolyzed in the cornea during penetration into its active form. It's interesting compared to PGAs, and it does seem to have more of an effect on the conventional outflow system in addition to the uveoscleral pathway, but that has not been confirmed with human studies yet. From the phase 3 trials, it has a similar ILP reduction effect compared to latanoprost. What's really interesting about the drug is it doesn't seem to have some of the severe side effects, the cosmetic side effects of prostaglandin analogs, particularly the prostaglandin-associated periorbitopathy. And in this study from Japan showed that omadanemag, compared to all of the prostaglandin analogs, really didn't have any of the PAP. Whereas if you look at that scale, latanoprost had the fewest of the existing prostaglandin analogs, and then bimatoprost had the most. This was approved in Japan in 2018 and then approved by FDA in 2022, but it has not yet launched in the US, so we're waiting for this medication. So what's on the horizon? So this is probably one of the most interesting drugs that are on the horizon. It's being developed by a company called Cularis Bio. It's based on an ATP-sensitive potassium channel opener called levchromacalum. Their prodrug is called QLS-101. These are some animal studies showing significant ILP reduction in mice, and you can see a nice drop in ILP there. It disappears after you stop the drug. But what's really interesting is the mechanism of action. So again, this is an animal study, but what they found is that there's no effect on conventional outflow facility, there's no effect on uveoscleral outflow rate, there's no effect on aqueous humor production rate. What it did was it reduced episcleral venous pressure. And so this is maybe the first medication that has reduction of EVP as its primary mechanism of action. And they just released their phase 2 data for their newest version of this compound called QLS-101. 2 phase 2 studies, one in untreated patients with POAG and arterial hypertension, reduced ILP by about 3.7 millimeters of mercury from a baseline of 23. But what's really interesting was the second study where they had patients who were already on latanoprost monotherapy, and they still had an ILP reduction of between 3.2 to 3.6 millimeters of mercury. They had really great safety profile, and they seem to have a similar ILP reduction, whether it's primary therapy or additive therapy, and that goes along with the idea that this is EVP reduction and not affecting another mechanism. So in summary, there are new classes of glaucoma medications that are becoming available over the last 7 years, and some that are still on the horizon after a 20-year drought post-latanoprost release. These new molecules seem to have reduced side effect profiles and also novel mechanisms of action, which hopefully will reduce ILP fluctuations, give us better additivity, and also have better efficacy in patients who have low ILP. So thank you very much. And again, hope to see everyone at WBC in a few months.
Thank you very much. That was very interesting.